That's some real upbeat music we got there going on. Welcome everyone to what's that? Magic's phone. Okay, well, welcome. I haven't done my YouTube thing yet. Welcome to PerfWeb 79. Is that right? Day 3? Yes. 79. The 73rd day of the 79th PerfWeb. That's amazing that we have come this far.
Wait till we're at 100.
I can't wait. We're going to have something special go on during that period of time. Anyway, let me get through all of our various different little comments, and then we'll get started on the program. So to contact us, you've got contact@perfusioneducation.com. You guys already know that. You got our contact number. Check out the scroll bar. And call in. We're still waiting. Anyone calls in, we're spinning the wheel 10 times. Okay, I'm going to get people to call in. It's going to happen one day. We're going to need a second phone line before long. The scroll bar that you see down below there, it has all of the information you need about the social media platforms. And I need to tell you, this is the first day, the first program that Magic just told me, that we are live streaming to LinkedIn. So I want to welcome our LinkedIn viewers. This is a real special day. It's your inaugural. And so welcome to the PerfWeb platform and program. I hope you enjoyed today. The MediWeb app, you go on the Apple Store, you could go on the App Store, you could go on the Google Play Store, and you can check out our app. There's 2 apps. One is the Critical Care Perfusion app, which is great for getting your pump cases ready in the morning or afternoon, whatever the case may be, for critical care nurses, for ECMO specialists, for critical care docs. And then there's the standalone app, which is incorporated in the big app, and that's the IV rate and dosage calculator. That is a fantastic app. But you get both. With the critical care app, you get only that. With the smaller app, one's $2.99, the other one's 99 cents. No need to buy them both if you buy the bigger one, which I recommend that you do. And it's only $2.99. I say it all the time. I only need to sell 999,999 more, and I'll be able to retire. Our podcasts, your favorite podcast streaming software, whatever that may be, you can go on there and you can listen to us while you're driving down the road. All of our programs are podcasted, so you can listen to the program on your way to work, on your way to the bowling alley, on your way while you're walking around the grocery store with your headphones on, whatever the case may be. I think it's a great opportunity for you to hear our dialogue. And the data, you may not see the diagrams, obviously, but the data is still, I think, in the opinions, the expert opinions are very worthwhile in that regard. So I want to, again, welcome you and to introduce, of course, Tammy. We all know Tammy. The Tammy Sparacino Journal Club is what we were doing. Tammy reminded me yesterday that she did not want it named her name, the Tammy Sparacino Journal Club, but that's the only way we could have done it. And she has done which one is this for you? Which journal club is this?
I think it's 30 or 31.
31. Wow, that's impressive. Okay, so today's topic is going to be a deep dive into neurocognitive decline in cardiac surgery. Is this a distraction rather than destruction? And just as a quick side note, I will say that neurocognitive issues following cardiac surgery, though way better than they were long ago, and what we consider acceptable when you compare it to the whole country, much in the same way I think we look at AKI or acute renal failure, and that worse, is that it's good when you compare it to everyone, but it could be better. And I think those are going to be hopefully you're going to answer some of those questions. Mm-hmm. Okay, very good. Tammy Sparacino.
Welcome, everyone. Thanks for joining us this morning. So as Joe mentioned, today we're going to be discussing a commentary article that was published in the Journal of Cardiac Surgery in October 2021. So it's very current. The title, Neurocognitive Decline in Cardiac Surgery, Distraction Rather Than Destruction. It is published by Dr. Caldozano.
Caldonazzo.
I don't want your help in this one, but yeah, thank you.
No problem. You told me your eyes were tearing.
My eyes are tearing up today, so you guys are going to have to forgive me. I'm having a little bit of trouble reading. And he is out of Germany, Jena, Germany, in the Department of Cardiothoracic Surgery in Friedrich Schiller University. All right, so let's talk about the abstract. Background. Neurocognitive decline is an undesirable event that can be observed in patients after cardiac surgery. It has been related to the use of cardiopulmonary bypass. Minor embolic or hyperinflammatory mechanisms are thought to be responsible. In this issue of Journal of Cardiac Surgery, their neurocognitive decline was observed in 22 of 30 patients after cardiac surgery with the use of CPB. Repeatable neuropsychological status tests were done, and scores of 4 days after surgery were 5 to 15% lower than before. Mechanistic investigations with glycemic control and transcriptomic and cytokine analysis failed to provide an explanation, but the frequency of the observation is worrisome. Discussion. However, available evidence suggests that neurocognitive dysfunction disappears within a few months, and later on, no difference to controls that did not undergo surgery can be detected. In addition, similar degrees of neurocognitive dysfunction can be observed after non-cardiac surgery and even after percutaneous coronary intervention. A most recent comparison of memory decline after CABG and PCI also suggests no difference between the two invasive treatment options for coronary artery disease. All of these findings argue against a primary CPB-associated mechanism. Interestingly, test subjects from a consumer investigation showed a 10% decline in working memory just by placing their cell phone on a table, suggesting that being distracted may also affect neurocognitive function. Given this reversibility of surgery and intervention-associated neurocognitive dysfunction, we question destructive, embolic, or inflammatory-associated mechanisms and consider distractive aspects of intervention-associated stress may also play a role. Their conclusion is, in any case, neurocognitive decline after cardiac surgery does not appear to be surgery specific.
That's very interesting.
Yeah.
I find that fascinating. That is a very good abstract.
Yeah.
And very provocative, very stimulating thought.
Okay, as I said, this is a commentary, so we don't really have any data to display, but we do have some interesting things to talk about. So I'm going to read to you some selections from the specific commentary, which is just a page long, and we'll talk about why this paper is published. So the authors had to look at an article that was published in the same journal in the same month that was looking at whether or not glycemic control affected neurocognitive decline, and those authors did not find that it did. They had little difference between the control group and the ones that did not have control for their glycemic.
But haven't we normally done that for infection? Isn't that more of an infection control?
No, from what I could read was they're trying to link all of this to certain genes that then cause the inflammatory response, and they're also they like to look at that with diabetes.
Okay.
So that's what they were kind of looking at. Although I didn't bring that article to discuss, in my research, that's what I found, that a lot of research has been done in that area. But what they talk about specifically in this commentary is how I'll read you this one paragraph. Okay, cardiopulmonary bypass is a key component in most surgical procedures, Cardiopulmonary bypass is a key component in most surgical procedures as it provides the basis for safe conduct of all the different techniques to address cardiac conditions. However, CPB has also been associated with undesirable adverse effects by causing, for instance, coagulation disorders, inflammatory response syndrome, neurological events in varying degrees. Even mild changes in neurocognitive function are often attributed to the use of CPB, suggesting that minor particulate or minor air embolism affects cerebral function. For decades, conditions known such as airhead or pump head were considered a given risk and just part of the package for being able to use CPB.
And I don't mean to interrupt you, but I think that was something that when we were using very rudimentary bubble oxygenators, that was that I do believe that was a real thing.
Right. No, absolutely.
Changed tremendously, but I think it was a real thing.
Right. With the advent of alternative treatment strategies, which they may be alluding to, whether it be off pump or just the techniques that have advanced with pumps, the ever-growing portfolio of interventional techniques not requiring CPB and other advancements, such complications may receive new value and new attention. Okay, so then they talk about the issue, the article that they are making a commentary on. So, neurocognitive decline in patients undergoing cardiac surgery using CPB as the subject was performed. These patients had performed repeatable battery assessment of neurological status test pre and 4 days postoperatively. These tests assess changes in short and long-term memory, language, attention, global cognition, and visuospatial function. They found that 22 of the 30 patients examined showed significant decline in neurocognitive function. Scores at 4 days after surgery were often 5 to 15% lower than before surgery. The authors excluded a possible relation to glycemic control, but were unable to provide more revealing insights despite sophisticated transcriptomic and cytokine analysis. Irrespective of possible molecular mechanisms explaining this finding, the fact that 3/4 of the patients appear to experience neurocognitive decline after cardiac surgery is highly disturbing and requires deeper investigation. The good news is frequent clinical conditions of this neurocognitive function decline is usually restored after 3 months, and at 1 year, the cognitive function is undistinguishable from patients that did not undergo cardiopulmonary bypass. In addition, postoperative neurologic dysfunction is common in all types of surgery, and its incidence is described between 5 and 15%. Certain high-risk groups, such as a hip fracture patient, may reach up to 60%. Thus, the association to the use of cardiopulmonary bypass may not be as clear as previously thought.
I think that makes a lot of sense to me. I think surgery in and of itself is stress-inducing.
Correct.
Anesthesia, we believe we know the effects of general anesthesia, but how much of that contributes. But one thing that you said that it has me a little bit confused, and then maybe you can clarify it, is if you're comparing this person to that person and saying that there's no difference in neurologic status, are they comparing the patient to themselves preoperatively, or they're comparing it to a control group?
No, they're comparing it to themselves. But because people have different baselines, right? But what they're talking about is the incidence of neurocognitive decline in patients that had cardiopulmonary bypass after 1 year. They have a control group that had tests done, initially, and then 1 year later also had tests done, just like the people who had CPB, and there was no distinguishable difference in the decline that occurred in people that had CPB versus people who did not have CPB.
Okay, so the decline is just a natural decline,
Right.
as opposed
Or none
to,
at all.
or none at all.
Right? So that's kind of the point, is that although CPB may cause temporary neurocognitive decline, at 3 months you can already see most of it has returned, and then at 1 year it is indistinguishable from their baseline.
And then they're also saying that it may not be the CPB.
Right, that's the whole
So they're
point.
just saying that following cardiac surgery or following
surgery. Right, following an intervention of some kind is what they're alluding to.
Yeah, that
Okay.
makes a lot. I mean, I think that's very telling.
Okay, I'll read you just a little bit more because this is a really great commentary. The neurocognitive decline has also been reported in intervention patient populations. In patients with non-STEMI, for instance, undergoing PCIs, its incidence has been reported at 28.8%.
Can you say that one more time?
So in patients that have a non-STEMI that then had a PCI, the incidence of neurocognitive decline has been reported at 28%.
Wow.
So even non-surgical, but just some kind of intervention, something invasive done.
That's high. I wouldn't have thought it was that high.
Yeah, a recent cohort study from the American Health and Retirement Study on 1,680 patients above 65 years of age assessed the change in the rate of memory decline after CABG or PCI. The authors found no difference between the two treatment options in the rate of memory decline. So what they're saying is surgery or intervention have the same rate of decline.
Wow.
For people over the age of 65. That's who they looked at. They did not compare the results to a cohort that did not undergo an invasive coronary artery disease treatment, but the lack of differences in this long term between CABG and PCI questions again the specific technical aspect of surgery as the sole cause for neurocognitive dysfunction. Current literature suggests that neurocognitive outcomes may be due to a hyperinflammatory state, which may be common denominator between all these observations. Let's see. Okay, so one author based their hypothesis on the inflammatory scenario and therefore investigated diabetic patients and glycemic control, where a pro-inflammatory condition is supplemented by the use of CPB. So these diabetics already have a pro-inflammatory condition going on,
Sure.
and then you put them on CPB, and so he tried to compare those and see how they affected each other. The findings, as well as the other observations of the neurocognitive dysfunction in the absence of CPB, question if CPB is a key contributor to the incidence of neurocognitive dysfunction and argue against a strictly embolic nature of the complications. While the present study that they're commenting on is too small to draw definitive conclusions, the findings may be used to question the role of cytokines, gene expression, and glycemic control as causes for perioperative cognitive dysfunction. They suggest future studies need to address the inflammatory states and how it affects neurocognitive decline and brain function as a whole. Okay. In this line of thinking may support alternate assessment of this phenomenon. Embolic and inflammatory mechanisms may trigger loss of cerebral function by destruction of cerebral tissues or cells. But what if surgical stress affects the allocation of cognitive capacities so that neurocognitive decline at 4 days after cardiac surgery would not be the result of embolic or inflammatory, but rather distractive mechanism? And this is, I think, the most interesting thing they discuss in this whole commentary. It is interesting to review a recent publication from a consumer marketing area subjected consumers to mental ability test in the presence or the absence of their cell phones. It's striking to note that the test subjects' working memory or ability to solve riddles experienced a 10% decline just by having their cell phone placed on the table in front of them versus having it removed into another room. It may be accidental that the amount of functional decline due to the distraction was similar to the neurocognitive decline measured in the above study 4 days after cardiac surgery using CPB, where the destructive mechanism is entertained. Although the many different tests and characteristics used and assessed may not be directly comparable, such a consideration may be able to explain why postoperatively neurocognitive decline is temporary, reversible, and not affected by diabetes, nor different between surgical or other interventional procedures. Therefore, the authors ask whether neurocognitive decline after cardiac surgery may be due to mental distraction rather than cellular destruction.
Now I know what's wrong with me. Magic, can you take my phone out of here, please? Now I know what's wrong.
Okay, so let's...
At least I have a reason.
I didn't click ahead here. So what were the problems to be solved? They were looking at whether or not we're actually destroying cells, hypothesizing. Is it more of an inflammatory or embolic destruction of cells, or could it be something as mere as you're extremely distracted? You've gone through these big procedures.
Stressful
You're in a
moment.
stressed
Heart
moment.
surgery is not a toenail removed.
Right. And how their methods and procedures, this was just a commentary, so they looked at current literature, and then we, of course, heard their conclusions, as should we be also looking at whether or not this is more of a mental distraction status. Okay, so that led me to this other article, which is an excellent article, and it is way above my pay grade for discussing, but there are some things in here that I think we could discuss and will lead to some interesting discussions afterwards comparing the two. So this article was published in the Biomedicine article. It's part of the Lancet Discovery Science online series. It's Surgery, Neuroinflammation, and Cognitive Impairment. It's by Alam and colleagues, published in 2018. Okay, here's the abstract. Trauma experienced during surgery can contribute to the development of systemic inflammatory response that can cause multi-organ dysfunction or even failure. Post-surgical neuroinflammation is documented phenomenon that results in synaptic impairment, neuronal dysfunction and death, and impaired neurogenesis. Various pro-inflammatory cytokines, such as tumor necrosis factor, thank you.
TNF alpha.
Yeah, alpha, maintain a state of chronic neuroinflammation manifesting as post-operative cognitive dysfunction, post-operative delirium. Furthermore, elderly patients with post-operative cognitive dysfunction or delirium are 3 times more likely to experience permanent cognitive impairment or dementia. We conducted a narrative review considering evidence extracted from various databases, including PubMed, Medline, and Embase, as well as journals and book reference lists. We found that further preclinical and well-documented clinical studies are reviewed to we found that further preclinical and well-powered clinical studies are required to delineate the precise pathogenesis of postoperative delirium and cognitive dysfunction. Despite the burden of postoperative neurological sequelae. Gosh, I have the worst time. Sequelae. Clinical studies investigating therapeutic agents such as, here we go.
Just say Dex.
Dex, ibuprofen, and statins have yielded conflicting results.
That's Precedex.
Yes. Yes, it is. In addition, evidence supporting novel therapeutic avenues such as nicotinic. I'm having the worst time.
That's okay.
HMGB1 targeting remote is ischemic preconditioning is limited and necessitates further investigation. Okay. So we got through that. Now here's a few things that I want to discuss. They have this great image where they talk about what happens after post-operative systemic inflammatory response, SEERS. So the cardiovascular system, you have lower contractility and lower SVR due to inflammation.
And we see that. That's kind of like having having the refractory hypotension that we see from this massive vasodilatory effect.
Right. Hypotension, hyperperfusion, you have increased myocyte apoptosis and cardiac remodeling. And looking specifically at the nervous system, which is, of course, going to affect the brain, which is what we're discussing today, is you have increased the blood-brain barrier permeability, you have direct cytokine-mediated neuronal injury, activation of the microglia, thank you, delirium, and long-term cognitive dysfunction. Okay. Here is another diagram, illustration, just showing kind of what happens to the brain cells. So you'll see that you have your surgery, then you have your DAMPs and your PAMPs, which DAMPs is damage. There are two types of proteins that the body can identify through toll-like receptors, the TLRs, and they're indicative of cell death. Okay, so what happens is these things are then identified and then in the cells, and you then have apoptosis and TNF alpha can be measured. So you have cells dying, you have hippocampal neurogenesis, you have a loss of synaptic connection, you have impaired synaptic plasticity, which leads to postoperative cognitive dysfunction and a higher risk of Alzheimer's. Okay. So here's just one table. We're just going to touch on a few things. So the pathogenesis of sears following surgical trauma and other diseases. So stage 1, you have initial localized inflammation to limit further injury and promote site healing following surgical trauma, infection, burns, various other conditions. Okay, so in that state, everything is sort of a local inflammatory response responding to activation. Okay, so you're going to have macrophages, neutrophils, all of that going to the site of the injury. Stage 2, you're going to have activation of early compensatory anti-inflammatory response called CARS, aims to restore the immunologic balance. So CARS is what happens there is you have lymphocytes working with against apoptosis, and they're trying to dampen everything that's going on, trying to return to that normal state. When you're in CARS, it causes a decrease in leukocyte antigen presenting receptors on monocytes, as well as increased production of specific cytokines such as IL-10 that act to suppress TNF expression. Okay. Ultimately, you're trying to restore normal immunological balance and response.
Homeostasis.
Right.
You're trying to restore homeostasis.
Okay. So when you're in stage 3, this is the overactive pro-inflammatory Sears reaction predominates over the anti-inflammatory response. So it causes endothelial dysfunction, increased microvascular permeability, profound vasodilation. You'll have the activation of the coagulation system, and other cytokines, specifically IL-6, stimulate the release of acute phase reactants such as C-reactive protein. Okay. Stage 4, the anti-inflammatory response is upregulated in order to compensate for the vigor of the systemic pro-inflammatory response, and the CARS eventually becomes excessive with profound immunosuppression or immune paralysis. Stage 5 is prolonged dysregulation of Sears and CARS response. This stage is referred to as the immunologic dissonance. The prolonged action of pro-inflammatory cytokines such as TNF, IL-1 directly alter endothelial surfaces, resulting in increased expression of a tissue factor. This initiates the production of thrombin, promoting coagulation, and also acts as a pro-inflammatory mediator itself. TNF alpha and IL-1 promote the production of plasminogen activator inhibitor 1, which then inhibits the process of fibrinolysis. Okay, so this is a pro-coagulant state. It's further upregulated via the complement cascade, which disrupt the activation of antithrombin 3.
So you have this
It's a back and forth.
massive pro-inflammatory
Right.
storm going on, and then you have your compensatory inflammatory processes, anti-inflammatory processes, which suppress become immunologically suppressed,
Right.
and then you still have all these massive inflammatories, and it's this rise in both of these results in a very bad outcome.
Right. So you start with getting inflammatory response, and then the body reacts with the CARs, and then the SEERs will, if you proceed along this pathway, will then amp up again, and then CARs will amp up again, and then finally if you're still haven't found a balance, then you're in stage 4, where everything is just out of whack, trying to control each other.
And this is something that, it's off topic, I hope you don't mind, but this is something that we have, that one of the reasons for high volume continuous veno-veno hemofiltration, not dialysis,
Right.
but using replacement fluid and having values that are much higher, up in the 35 to 45 cc's per kilogram per hour of effluent and replacement volume.
It's to remove all of these mediators, right?
Right. You will remove the pro-inflammatory mediators, but you will also remove the anti-inflammatory mediators. Whichever is higher, because the concentration is higher, you will remove preferentially, right? But at some point, you reach that balance that you're looking for in the body by removing them. Now, sometimes these inflammatory mediators are too large for the hemoconcentrator or the CVVH filters that exist, which have cutoffs about high. I think the larger size goes up to 60,000 Daltons, if I remember right. 50 is normal. I think they go up to 60 or 65 because you don't want to remove proteins, and albumin's right at about 60, 65 kD. But if you take if you use the plasma, the MARS system, the molecular adsorption recirculation system, where you're actually, or the cytosorb. This is what
the cytosorb is for.
That's what cytosorb is for. Whether it be the MARS system, which is a little different than cytosorb, because the MARS system removes plasma from the red cells, and then you ultrafiltrate the plasma as well as run it through an adsorption filter, and then reconstitute
it comes
the plasma
back in on
and
the
the
other
red
side.
cells
Yeah.
back into the patient. Whereas the cytosorb is a whole blood cleansing process, filtering process, or adsorption process is a more appropriate term. So it's very interesting because this is something I think that we really don't think about. And I don't want to, are you ready to discuss this?
No, I've
or
got
you
a
have some
couple more points.
I'm sorry, let me stop talking.
Okay. No, I think that's all.
I'm sorry.
That's all important, especially when we're talking about, this whole pathway that goes on after.
That results in death.
Right. It will. Okay. So here's just some. Like I said, this is a very lengthy article, but there are some things I thought were interesting to apply to our the article that we are discussing. So consequences of neuroinflammation. Post-surgical neuroinflammation causes a variety of structural functional alterations, and these are the ones that are most important, and that have the biggest effect. So you have synaptic dysfunction, you have neuronal death, neurogenesis impairment, and GSK3 dysregulation.
I don't know what that is.
It's I have it right here.
Thank you.
It's glycogen synthase kinase 3. It's a serine threonine protein kinase, which possesses significant pro-inflammatory effects within the brain. So it can cause it, if it's in dysregulation status, it can cause the brain to become pro-inflammatory, which is
Gotcha.
not good. Okay.
As a selective organ, not necessarily systemically.
Right, as a selective organ. Correct. So just talking just briefly about the synaptic dysfunction. So synaptic impairment has classically been considered a characteristic feature of a late-stage neurodegeneration. It has more recently been heralded as an early indicator of dementia progression. Surgical trauma results in the pathological activation of astrocytes, thus causing the release of pro-inflammatory cytokines and subsequent synaptic dysfunction. So what they're saying there is when you have synaptic dysfunction, that is an indicator, it releases pro-inflammatories, and then that can be an indicator of dementia progression. And all of this can be caused by surgical trauma.
Just by the stress of surgery itself.
Right.
Again, general anesthesia, incisions, opening the belly.
This is specifically talking about surgical. We'll get to anesthesia, I think, shortly. There's another discussion about that. So, okay, then neuronal death. So the process of post-surgical neuroinflammation also involves several pro-apoptotic pathways and activation of TNF, which will signal promotion of apoptosis. Increased TNF correlates with increased hippocampal neuron apoptosis. Okay, so just having surgery can also cause this, the stress of it. Recent studies have identified that peripheral surgery causes a reduction in cerebral acetylcholine, thus triggering a complex neuroinflammatory response. Okay, so if you'll notice, the theme here is pro-inflammatory is the result of surgery and causing different things. Neurogenesis impairment. Neurogenesis describes the maturation and differentiation of neuroprogenitor cells to neurons. This process of neurogenesis is confined to subventricular zone of the walls. Pro-inflammatory cytokines can inhibit neurogenesis. So in other words, the pro-inflammatory is now going to stop neurons from being in the pre-neurogenesis stage, developing fully. Okay? And then the last thing, the GSK3 dysregulation. So a positive correlation between GSK3 concentration and blood-brain barrier permeability has been demonstrated and can facilitate the migration of leukocytes across the BBB. Okay, so
and that's a problem.
That's a big problem.
Migration of leukocytes, whether it be through the blood-brain barrier or in the cases where we are very much involved, and you look at ARDS, pulmonary-wise, and we frequently, that is what you see, is just a massive infiltration of leukocytes into the alveolar capillary wall. And I mean, of course, you have, asthma, which is from neutrophils, right?
Neutrophils.
So neutrophilic asthma. So there's a lot of this phenomenon, this inflammatory process that happens with the white blood cell leukocyte.
Right, and we could look at this article actually looks at all aspects, not just the brain, but I'm just concentrating on the brain aspect since that's what we are initially discussing. Next, we're going to talk a little bit about the post-surgical neuroinflammation reduced neuro disorders. So this is where we can talk a little bit about anesthesia. So the first part, post-operative delirium or POD. We're all familiar with delirium as an acute confusion state that is characterized by fluctuating nature and reversibility associated with dysfunctional mental state and inattention, typical time and a typical time course. A diagnosis is usually made when the patient conveys differentiating perceptions. POD has an incidence of 37 to 46%. Differs on the type of surgical procedure carried out and can be as high as 51%. Adverse effects are often common, include increased length of stay, associated healthcare costs, and increased mortality. Anesthesia has classically been considered the major contributor to postoperative delirium. Some animal studies indicate that surgery-induced inflammation may be a significant cause of POD, associated neurological impairment as well. So just having surgery can cause delirium because of these pro-inflammatories. Next, we'll talk a little bit about the postoperative cognitive dysfunction, POCD. So due to the surgery-induced systemic inflammatory response, patients may suffer from POCD. It's usually observed in the immediate post-operative period and manifests as transient disturbance in cognition. The disturbance presents as a spectrum from lethargy to social withdrawal and reduced concentration to severe cognitive dysfunction. It also can fluctuate consciousness in the sleep-wake cycle irregularities. Elderly patients do have a higher incidence of POCD. Patients age 60 and older, the rates can be as high as 40%. An increase in pro-inflammatory cytokines intraoperatively, potentially short-term cognitive impairment. The increase from pro-inflammatory cytokines intraoperatively potentiates short-term cognitive impairment. In addition, reports from animal studies have suggested TNF-mediated dysfunction of the blood-brain barrier and subsequent migration of leukocytes into the hippocampus have the ability to cause memory impairment. POCD is more common following a major surgery and in the presence of postoperative complications. It's traditionally considered a complication that occurs following cardiac surgery, but epidemiologically, evidence suggests that the condition is also prevalent following various other surgery procedures, including abdominal surgery. Both surgical trauma and neurodegenerative disorders are associated with this increased cytokine release. Then lastly, we're going to talk just a little bit about other neurodegenerative conditions. Alzheimer's disease is a chronic neurodegenerative condition, is most frequently diagnosed form of dementia. Both POCD and Alzheimer's share the common feature of increased increased microglial activity, which ultimately results in profound neuroinflammation. It is important to consider the fact that these inflammatory processes are not resolved as effectively in elderly patients in compared to younger population. Therefore, it is hypothesized that due to this process, whereby the accumulation of abnormally folded proteins and neurodegenerative due to changes that result in abnormal microglial activation and multiplication. This may explain why retrospective studies have suggested that the rates of POCD and postoperative dementia are higher in older patients. And that's it. Then this article goes into a whole bunch of stuff about novel uses for specific medications that we'll leave for another time.
Mm-hmm. Very good. So, you know, just from a commonsensical perspective, if I may,
Mm-hmm.
we're going to take a patient whose heart's beating, they have a relatively normal blood pressure, they may be on some medications, maybe they do have diabetes, we'll say it's diet controlled. We're going to bring them into the operating room, we're going to make a big incision in their chest, saw their sternum open, put a retractor in it and yank it open, cut the pericardium, put stitches in the heart in various locations, insert these tubes. We're going to then divert their blood supply in its entirety to our venous reservoir of our cardiopulmonary bypass system. We're going to turn on our arterial flow. We're going to start flowing. We're going to change their hematocrit from whatever it was to whatever it is, which is going to be lower by a, varying degrees, depending on how much prime you have in your pump and whether you put blood in it or not and all that kind of thing. But you're going to have an acute hemodilution effect. Regardless of how minimal it is, it's still going to be a hemodilution effect.
Okay.
You're going to, of course, take away the pulsatile flow, and the pump, no heart-lung machine is going to be able to, and it's really not because of the heart-lung machine not being able to do it or the centrifugal pump. It's more because of the aorta is usually, 3.5 centimeters. Is that about right? 3 to 4 centimeters, somewhere around there. And our cannula is, at best 22 French. Much smaller, so it's very hard to generate that same pulse that you would from a left ventricle going into the aortic, the left ventricular outflow tract through the aortic valve into the aorta. Much larger. You would have to have a cannula that same size and tubing all that same size, and the length of it and all of that is going to have an effect. So your pulse is, from bypass is not physiologic.
Correct.
No matter what you.
Even if you use pulse tau flow and all of these things.
It's not physiologic.
Right.
I don't know why we do it, but some people think that it really makes a difference. It doesn't.
Your opinion.
Yes, my expert opinion at that. But we're going to do that to you. So we're going to take away your pulsatility. We're going to dilute you. We're going to cool you. We're going to...
Maybe.
Yeah. We're going to put a clamp on your aorta. Think about the baroreceptors and the chemoreceptors that have now been completely thrown out of whack, at least transiently. We're going to change, your right atrial pressure is going to go to 0 from, let's say, 7 or 6, 7, 8, 10, somewhere in that range. And so you're going to have receptors that are going to sense that as well. They're going to see it themselves as very empty. And there's a reaction to that. So we do all of this. It's very difficult for me to say what we're doing is not causing harm.
Well, it is.
Yes, that's my point.
I don't think anyone would argue with that.
It's the degree of harm we cause. And what are our mitigation strategies for that harm? How does it affect the brain? One of the things that recently came up in a situation that I'm involved in is if we let the blood pressure drop to, the brain auto-regulates very well, but if your blood pressure gets below a certain range, or your flow and pressure get below a certain range, you now need a capillary opening pressure to get flow going to the brain.
Okay.
So how long is the blood flow to the brain? Because we have those episodes happen all the time. Turn the flow down, turn the pump off. And you do that, and we make some maneuvers, and although it's just for a short period of time, we come back up. But we don't really know what the flow to the brain is. Now, we use some surrogates for that. We use cerebral oximetry. That is, I believe it's become a standard. I think it is a standard. I think that, I've had some concerns about the use of it, but if you use it, you use it. If you don't use it, then you don't use it. But if you're not using that, then you're completely blind unless you're using transcranial Doppler, which would probably be a little bit better for flow. But again, flow in and of itself isn't the only thing. There's all kinds of other things. You could have flow, but if you have this, as you said, this inflammatory process that just happens, how do we measure it? How do we address it? What do we do? Or do we just simply accept that the body, for all intent and purposes and for the overwhelming majority of patients, can simply adapt to it? Is that really where we're at?
Are you asking me?
Yes, I'm asking you, Tammy Sparacino.
I don't know how we could measure it. Especially surgery is such a small portion of time, even a long surgery. How you would measure inflammation is you'd have to be running some kind of blood test. So you'd be drawing blood tests, sending them to the lab. I just don't think that that's very practical for what we're doing, even in a 6-hour surgery, right? And because even if you had that information, what are we going to do about it? We're not going to stop the surgery.
Right.
The insult is not over. until we're done, right? We have to finish what we came to do.
And it probably lasts a little longer after that.
Well, yes.
Because you have to wake up. I mean, the stress associated with waking up
Well,
after
and
heart
I
surgery
think it
is
shows
probably
it does
significant.
last at least 4 days because
Yeah.
people are often tested at that increment 4 days after, and you still see neurocognitive decline. So that is caused by something, and if we've eliminated that, the overwhelming majority of it is some kind of particulate matter, that has caused loss of blood flow to the brain, which maybe
An embolic event.
yeah, maybe sometime in our, not too far past of cardiopulmonary bypass, that was the overwhelming majority of what it was. But I think today that's unlikely that that's what it is most of the time.
Yeah, true. And also, based on your data, based on what you've elucidated for us today, it seems that the amount of decline, which would be a clinical an outcome that was clinically relevant, right?
Right. You
Clinically
can measure.
significant.
Yeah, you have to measure it and
Right.
score it.
Right. That cardiopulmonary bypass, though in my view traumatic to people, is in and of itself no more traumatic than the surgery itself, even if it were done without cardiopulmonary bypass. That's what I understand you to
Yes,
say.
that's exactly what they're saying. And they're what they also, I think, kind of what their clever title is really trying to hit home is, yes, it is likely that there's pro-inflammatory going on, which is destroying brain cells. And there is a cause and effect relationship, right, with losing brain cells or damaging brain cells and then neurocognitive decline.
And depressed neurogenesis to replace those nerve
Right.
cells.
All of that's going on. And I don't think anyone would necessarily argue that. There's lots of studies, lots of papers that have been written on that. What's causing it, we don't know exactly. We have some ideas. But what is unique about this paper is they're also talking about that the types of tests that we use post-surgery to test neurocognitive dysfunction could also, they're not specific enough to be able to, because they're just questions, right? They can't tell what caused it. So maybe it was some of the pro-inflammatory destruction things, or maybe it's just that your whole mindset after a major surgery, you've had anesthesia, you're in a place that you're not familiar with. All of those things also are very distractive.
And stress inducing.
Right. But even just distraction.
Yeah,
So,
distraction,
right.
yes.
This phone, it keeps texting. And when you're talking to me, even though I'm paying attention to you, what am I doing? I'm glancing. I'm
Yes.
seeing, do I need to deal with this? That's distractive, and therefore, if you then asked me afterwards, what did we talk about? I likely missed some details, and if you looked at that alone and didn't know that I was distracted by my phone, you might think I'm not paying attention, or I might have some kind of neurocognitive dysfunction going on, right?
Yes.
And I think that's their point. It could be, this could be a part of what's going on, and if so, that makes a lot of sense on why it's reversible, because being distracted doesn't cause brain damage, right? It's a temporary state that once you are not distracted anymore, you should have your full cognitive function.
Yeah, it's not a fair representation of actual capability.
Right, exactly.
So I get that. That makes a lot of sense to me. Yeah, very good. Very interesting, I think.
I
and
thought
I
it was
think
interesting.
very positive for us and our
Yes.
profession of perfusion. In fact, since we're on air, I think you should tell Dr. Bhatia right now, Devendra Bhatia, that the pump is your friend. Just go ahead and say it. Do it. Come on, because I'm going to use you in my debate. I'm going to pull this recording out and use you
The
in
pump
my
can be useful, and I do promote it. It is what I do. But it doesn't mean it's applicable to all patients and all surgeons and their techniques.
Well, I'm going to find the paper that says that neurocognitive decline is far worse with off-pump coronary than with on-pump coronary. I will find that
It's going to be a great debate. That's in June.
That's
yes?
in June, yes, of 2023. That's correct. Okay, so do we have any questions from our audience? If we do, the phone line's open. You can see it there. And I know it's not going to ring. If it did, I would be shocked. I'd probably fall out of my chair.
And again, I know a lot of this is some high-level stuff.
The second paper, it was not just over your pay grade. It was well over my pay grade too.
Very interesting, but it's not light reading.
No, that's intense.
Yeah,
very much so.
It's pretty intense, and it's actually really. I thought it was really well written. So if you're into that sort of thing, you want to learn more about it, you want to stumble over some words, then give this a read.
Give that a read.
Yeah.
So let me ask you this, if I can. Do you think, now that you've done these journal clubs, 30, what was it, 29 of them?
I think 31.
31 of them?
Something like that.
31 journal clubs. Has this, been a value to you?
I mean, for me personally?
Yes.
Yes.
Yeah, you personally.
Yeah. Well, I'm curious by nature, and you don't always make time to look into things that are outside of your everyday. And I think this journal club gives me an avenue and a motivation to do that. And I'm hoping that's what it does for other people. You may not think that this paper or the other paper or whatever that I've talked about is specifically useful or interesting to you, but I hope that at minimum it sparks interest in something I may have said or made you think of something else, and then that you are able to go investigate it. Because after reading all of this, I want to know all about pro-inflammatories. I know some about it, but it's been a long time since I looked into it, and now I'm curious. And then that led me to, I wonder how much distraction in modern life and how that affects just our abilities and everything, how we interact with other people, how we parent, how we do our jobs. I think that's all very interesting.
I think it is too. That's a very, very good. That's a very good point. That is how I feel as well. I've learned more since we started this program than I ever thought I would learn, and it's taught me the one thing that probably has taught you the same is I don't know as much as I thought.
What I know, you can fit in a bowl that you water that screaming goat with.
Hey, you know what, Dave? Have you seen this? You haven't seen it, have you? Showtime. Hey, everybody! If anybody calls in, I told you, if you call in right now, you're gonna get 10 spins. Otherwise, you just get this. You haven't seen that?
No.
Anytime somebody says something that, like, come on, really? Like somebody says something, you get that. You got the screaming goat.
I notice it's only directed like when you speak. You should really flip that goat around so it faces you. It's never going to be addressing me.
Probably so. I just think it's a good tool to use for when we have a panel, maybe more people,
yes,
as we move forward. And you know how sometimes somebody says something and you're like, well, yes, I don't know that yeah, there we go. See, even David knows when we have to do it. All right, very good. Okay, how about let's spin the wheel. We're going to spin the wheel.
Questions?
We don't have any questions. We have no questions.
Who am I going to spin it for?
We're going to spin it for you. We're going to spin it. You know what? Let's spin it for David. David never gets anything.
Does David want anything on here?
Huh? Probably. Let's see.
All right.
All right, that's enough. That's enough. I've created a monster here.
Okay, let's get
the
wheel.
Let's do the wheel.
All right.
We got to do the. Aswani Suradran is watching. Sarani or Aswani, ask anything. Okay, if you do, just say hi. All right, this is going to be for Aswani unless we hear nothing, and then it'll be for David. So let's see what David's going to get.
Oh, David, I'm sorry. Oh, thank goodness.
Yay, a cup. He doesn't get an aortic dissection. I can't believe it.
I already had one of those this week.
Yes, you did. You did. And okay, very good. So we'll see you all
May 24th, maybe? 21st,
Let's see.
May 21st.
Let me pull it up.
Right before Memorial Day,
Schedule-
we've got a couple programs.
Yes, so April, so this is April. We've done May 24th, 25th, and 26th.
What's on the 21st?
Yes, on the 21st is going to be, we're going to have Tabby here from Thailand.
Oh, May,
And-
yes, she's going to be visiting.
May 21st. It's going to be on a Saturday morning. It's going to be great. I need to get that up. I need to
It's
get
not on the schedule
get
right
it
now.
submitted right.
Yeah.
Figure out what it is, and we're going to do. We're going to have her give a lecture here, especially for her peeps in Thailand. And we're going to have we're going to have a great discussion with her, and then we're going to have a great crawfish boil. We're going to invite a whole bunch of people. We'll have a good time. And anybody out there in web world that may want to come to the studio and be part of the studio audience and join us with meeting everybody, just reach out to me at contact@perfusioneducation.com, and we will work that out with you. So we're looking forward to the 21st, and then the 24th, 25th, and 26th. You're going to be doing perioperative stroke before
Yes.
cardiac surgery.
Yes.
Does not increase postoperative stroke. We're going to do a fireside chat with Matt Warhoover, and we're actually calling it, what are we calling it again?
5-alarm chat.
5-alarm chat.
Conversations at the Inferno.
Conversations at the Inferno, and that's going to be on DCD, organ availability, and work-life imbalance.
Yeah.
Notice how I put it that way.
Yes.
And then on the next day, the 26th, we're doing a fireside chat, disparities in ECMO outcomes. And this is going to be very interesting, too, because I recently read another article where their VV ECMO rate of survival was about 50%. Maybe a little under, and I had showed you that other one where it was 90%, and then we've
Patient
seen
selection.
Yes,
Preferential patient
there's
selection.
There's a lot of information in here that I find fascinating. Their average time on ECMO was only 14 days
Oh,
for VV.
that's nothing like
And
what we
so-
saw.
But but if you look at the diagnoses of the reason they were on ECMO, well, I've got the article. I don't want to say too much about it, but it's going to be a very interesting fireside chat with some provocative data that I think will be very important for everybody to hear. And we're still working on our outcomes, I believe. We're still trying to get that done. I know I gave you that list. And I know it's been busy, so we haven't had a chance to really get into that. But we do need that. I do want to get that by May 26th. if
Yes,
I
you can present it. Yes, absolutely.
Yes, please. Okay, thank you all very much. We will see you on the 21st. It's not on the web yet, but it will be, and everybody will be sending an
And
invitation.
we will have a special guest of honor.
Special guest coming from Thailand here. So Tabby, her name is Super Porn.
Yes, I don't know if we
that
say
I say
it
her name
correctly,
right.
but
so
she
we're
is our
hoping
dear
she
friend
will-
from afar, and we're looking forward to meeting her in person.
Absolutely. So I'm looking forward to that. Okay, thank you, everyone. See you. Peace out.